All right, you guys, let's go ahead and get started. We are recording at this moment. So let's go ahead and start with the GI physiology section. This is lecture 16. The final exam only covers lecture 16 and 17. All right, so I need to get back to the beginning of this lecture. All right, so let's just start from the top. We'll just go through it pretty systematically, you guys. What we're talking about here is an organ system. Okay, so the GI tract is essentially an organ system. It's made up of a number of different organs that all play a role in similar function. So we're talking about motility, digestion, absorption, and secretion. Okay, so those are the four major processes: digestion, secretion, absorption, and motility in the gut. So let's go back. Basically, like I said before, there's a number of different organs. They all make up, like I said, if I put a tube down my mouth, down my esophagus, through my stomach, small intestines, large intestines, out the rectum and anus, the entire system is called the alimentary canal. Alimentary canal. And we're going to go through all of these different parts. We're going to start up with the upper GI tract, talking about the different salivary glands. The ones that we really are going to focus in on are parotid, sublingual, and submandibular. The mouth and the tongue here actually pushes the bolus of food that you eat, to the back of the throat, called the pharynx. The epiglottis bends down to protect the trachea when the food slides down from the pharynx into the esophagus. The major mode of motility in the esophagus, we talked about peristalsis. And then it enters into the stomach. You can see the stomach right here on the side. We see the stomach, the liver on the other side, on the right-hand side, and the gallbladder, the pancreas. And so food from the stomach enters then into the small intestines, the three major sections: duodenum, jejunum, and ileum. Okay, and then the food actually enters into the colon. Remember, the colon has these pouches called haustra. You have an ascending, transverse, descending, and then you have a sigmoid colon, rectum, and anus. So all of the colon, cecum, rectum, and anus, well, not the anus, but all of this is the large intestines. Okay, so do know some of the parts associated with the GI tract: upper and lower, gastrointestinal tract, and then the function. So the four processes carried out by the GI tract: digestion, secretion, absorption, and motility. Now, I'm not going to assume that you guys remember this from the kidney, so I want to make sure that you guys know the difference between absorption and secretion. So whenever you absorb certain molecules like calcium absorption, what's happening is that you're pulling these molecules out of the small intestines and transporting them into the blood. So that's called absorption. Secretion is the red line here, the red arrow. It's going in the opposite direction. Secretion goes from the blood and it's secreted into the small intestines. We talked about a secretory diarrhea, which actually transports water into the small intestines. Secretory. Now, anything you absorb, this is another thing. Anything that you absorb from the intestines actually travels to the liver through the hepatic portal vein, and then to the heart. Okay. All right, so any questions so far? Just some general anatomy, really, right now. So if you want a little bit more detail, this breaks it down, right? And we're going to cover this, but if you want a nice, succinct diagram that gives you a good idea of all the different organs, mouth, salivary glands, esophagus, stomach, pancreas, liver, gallbladder, small intestines, large intestines, you can kind of read through here. This is a nice review slide. So many of the functions in the gut are found in specific locations along its length. Most of the absorption of nutrients occurs in the small intestines. So most of the digestion is accomplished there or upstream. And then I wanted to just focus in on water for a minute. So most of the digestive secretions are water. And you can actually see, this is actually pretty impressive when you think about it. All of the water that you drink during the day, 1.2 liters. And in addition to that, the salivary secretions, 1.5 liters. Gastric secretions, that's in the stomach, 2 liters. All of that, most of it, I should say, most of it is absorbed in the small intestines, almost 7 liters of water. In addition to about 2 liters when you're talking about the gallbladder, the bile, and the pancreatic secretions. An additional 1.5 in the intestines, and then almost 1.5 is absorbed in the large intestines, but the bulk of it is in the small intestines. You really only get rid of about 100 mils of water in feces. So that's very little. So now going back to cholera. Actually, after we have had this discussion in class, you can see how cholera is so devastating. So instead of being able to absorb 7 liters in the small intestines, now think about it this way, with a secretory diarrhea like cholera, where it turns on adenyl cyclase, it keeps it in that on position, and instead of 7 liters being absorbed, you get 7 liters being secreted. You can literally lose your entire bodily fluids in a 24-hour period. That's why cholera is so devastating. I always wondered about that too. How can, in a 24-hour period, how can that kill someone? But if you're not absorbing all of that water and you're actually secreting it, yeah, it can be very devastating. So the GI tract is made up of various compartments. They're specialized compartments that have different pH, different enzymes, and they're all separated by these muscular valves called sphincters. So I think the major one that we talked about was the upper esophageal sphincter, the lower esophageal sphincter called the cardiac sphincter, and the pyloric junction. Some people call it the pyloric sphincter, but I'm going to be very technical about it. Tell you it's not a true sphincter, so I'm going to call it the pyloric junction. And that's the entrance from the stomach into the small intestines, the duodenum. And again, these compartments vary in pH, enzyme composition, and types of secretive and absorptive cells. There's a lot of complexity of gut morphology across different taxa, but this not being a comparative physiology class, I'd love to develop one just to be able to talk about differences among species. But, okay, so again, we've already kind of gone through this figure, so I'm going to skip to the next one. Let's start off by talking about the upper digestive system. And the first thing we talked about was teeth. So molars, you have 12 of those usually. Some people have their wisdom teeth taken out, so that's not always the case. But molars, premolars, there's 8 of them. Canines, and then 8 incisors. Those are the front ones. I guess just to remember, the molars and premolars are about chewing and grinding. The canines and incisors are mainly about tearing, biting and tearing. All right, so we went through a little bit of this information. We talked about the teeth, and I told you guys about the enamel. Enamel is actually the hardest substance in your entire body. It contains the highest percentage of minerals, 96%. And then the last 4% is just water and organic material. The dentin is also calcified tissue, and it's one of the major components of the tooth. Okay, so it's not as hard as the enamel, but it's still calcified. So the gingiva is actually the gum line. Pulp cavity is where all the living tissue is. This is where all of the blood supply, the lymph material, and the nerves lie. So it is basically soft tissue in the center of the tooth that contains the nerve, blood, and lymphatic vessels. Okay, so the nerves actually run through the roots, the legs of the tooth, and then you can actually see the periodontal membrane here too. So I think that's interesting, the periodontal membrane. It is fleshy tissue between the tooth and the gum, the bone there. Not the gum, but the bone. And it actually holds the tooth in place. So it's attached to the adjacent teeth and enables the resistance of the stresses of chewing. So it's a buffer, basically. And then the bone is here. So anything above the gum line, that's called the crown. Anything below is called the root. Okay, so also in the mouth, we concentrated on saliva. And for the exam, there will be a few questions on salivary glands. The 3 that I want you guys to know are the parotid, submandibular, and sublingual. And I think the major thing that I really want you guys to know is that the salivary glands already are producing amylase. They secrete various compositions of mucus, salivary amylase bicarbonate, and already an antimicrobial called lysozyme. Okay, so you guys remember what amylase is? Amylase? It is an enzyme that starts to break down carbohydrates. So this is an enzyme that breaks down carbohydrates. Yeah. Yeah.
One of the questions was if the saliva isn't releasing amylase, what would that do to starch digestion?
Yeah.
So, I mean, would it really affect anything, or would it just not make starches taste sweet?
Oh, good question. Is there anything else in the body? Okay, so the question is, if the salivary glands are not producing amylase, how is that going to affect the body, right? Is there any other organ that could compensate for the lack of salivary amylase? Yes. So it will have some effect, but the pancreatic amylase should actually compensate for that, yeah. So I think that's what the answer is, really. Pancreatic, there is some redundancy in the system, and the pancreatic amylase will take over. So I see what you're saying, though. If it doesn't break down starches into glucose and fructose, It may not trigger some of the sweet taste receptors that are in the gut too. That's a little bit more sophisticated than the answer that I wanted, but you could be right. I just am unsure about exactly how that would affect some of the sweet taste receptors. But there's some redundancy in the system, so the pancreatic amylases would take over. Yeah, good question. Okay, so the parotid gland is the largest one. And you can see, I kind of had you guys run your tongue up against your cheek, right? You can actually feel the opening where the parotid gland, mine's right here on the top. I can feel it. It's just like a little knob, like. So, what this does, you're like, oh, really? Okay, so what this does is it actually produces a very watery secretions. Serous. Serous is another term for watery. Watery. And it actually produces the majority of salivations during rest, at rest, when you're not eating a meal. So if you get a question about the parotid gland, I think the major characteristic is that it is secreting a very watery secretion. Now, on the opposite extreme, sublingual gland is responsible. It only produces about 3 to 4% of total salivary secretions, but the secretions are very rich in mucins, very mucus-like. I gave you guys the example of a Saint Bernard, right? That's where, when dogs too, they get those long drools. It's the sublingual gland that is producing most of the mucin-rich secretion. And then the submandibular gland is intermediate between the parotid and the sublingual. So some mucus, some serous. It's not as watery as the parotid gland, but not as thick and rich in mucins as the sublingual gland. All right, salivary gland. So what does saliva do? It lubricates the food, starts to break down polysaccharides, those are carbohydrates, by secreting amylase, dissolves the food so nutrients can bind to taste receptors, and then the lysozyme that it secretes also cleanses the mouth with antimicrobial properties. So this is a harder one because there's no text associated with it, so I'll walk you guys through it. This is a typical salivary gland. It's an acinar gland. Acinar has an acinous portion. Acinar is spelled A-C-I-N-A-R. It's an acinar gland that has two components. The acinus is the bulb-like structure, and then it has these duct cells. So the primary secretion from the acinar cells is very plasma-like, right? Because basically what's happening is plasma is being forced from the capillaries, it's being transported across the acinus, and the primary secretions are very plasma-like. So, in other words, they're isosmotic. It has the same osmolarity as the plasma in the blood. Then what it does is it's forced into the duct portion where the primary secretions are usually modified. A lot of times you can see salt is reabsorbed, so there's transport properties that are pulling sodium and chloride out of the duct, meaning the salivary secretions can be hypoosmotic, depending on the rate of secretion. Now you can also see that at the neck here, you can see these myoepithelial cells. These are myo meaning muscle. They're smooth muscle-like cells that surround the neck of the salivary glands and can control the flow. And then what's really interesting, these are symbolizing different neurons. You can see that there's innervation to the capillary beds, but also to the acinar cells as well, and these myoepithelial cells. And what's cool about it is both the sympathetic and the parasympathetic nervous system increases salivary secretions. It's one of the only structures, organs, that's activated, stimulated by both the sympathetic and the parasympathetic. All right. So we did go through some of the taste receptors, but this won't be on your exam. Some of you guys have had this information in the lab. There's salty, sweet, bitter, sour, and umami. Umami is a taste receptor that detects amino acids, savory type of foods. And we talked about this in class. Remember, there are sweet taste receptors in the gut. Remember, we did talk about this in lecture, in the GI lecture. If there's high glucose levels in the gut, it actually inserts more sodium glucose transporters, SGLT1s. So if you get more SGLT1, you can actually absorb more glucose when there's high glucose levels in the small intestines. Because of those sweet taste receptors, it's detecting the higher glucose levels, and it's inserting those transporters to enhance glucose absorption. That's why you can't lose weight with Diet Coke, right? Whatever you eat with that Diet Coke is triggering those sweet taste receptors, inserting more glucose transporters, and you're actually raising the glucose levels in your blood as a result. So, interesting. All right, so let's talk about the swallowing reflex. It's all coordinated by the medulla oblongata, which stimulates contraction and relaxation of both skeletal muscle, sphincters, and smooth muscle groups. Just remember there's two different phases. There's a voluntary phase and there's an involuntary phase. So the voluntary phase is this: you actually push the food with your tongue to the back of your throat into the pharynx. Okay? So initially, the muscles keep the esophagus closed, but then the involuntary phase, you actually get the epiglottis. Okay, so here's before. You can see the epiglottis is kind of up like this. And then when you swallow the involuntary phase, the epiglottis bends down to protect the trachea. The soft palate also rises to protect the nasal cavities. And then that bolus of food slides, after the upper esophageal sphincter relaxes, that bolus of food actually slides into the esophagus. Okay, so then we talked about the esophagus itself. Do you guys remember which type of muscle is controlling the upper esophagus and which type of muscle is controlling the lower esophagus? There was a distinction. Perfect. Skeletal muscle is controlling the upper esophagus. Smooth muscle is controlling the lower esophagus. So for dogs, for instance, I said this was one of the examples that I rolled off. So they can't tell you that they have myasthenia gravis, the weakening of skeletal muscle. It's an autoimmune disease that attacks those nicotinic acetylcholine receptors, and it causes generalized muscle weakness. It only affects the skeletal muscle in the upper esophagus. So when these dogs, they're very lazy, they're, having a hard time being active, if you bring them in and they image the dogs, they may have what's called mega esophagus. The generalized weakness in the upper esophagus causes it to expand, and sometimes food accumulates in that area. Again, this is a symptom called mega esophagus. And it would only occur in the upper esophagus because that's under skeletal muscle control. Below that, smooth muscle control. So, the coordinated sequence of contraction and relaxation in the upper esophageal sphincter, the esophagus and the lower esophageal sphincter, also called the cardiac sphincter, is necessary to deliver swallowed food to the stomach. So it's really about transporting food from A to B. But I think this is really interesting. This gives you an idea of how the upper esophageal sphincter and the lower one works. Okay, so again, this is a series of pressure changes in the esophagus as you eat a meal, as you eat a bolus of food. The first thing I want you to notice is that most of these start off at 0, except the sphincters. The upper esophageal sphincter starts at 30 millimeters of mercury. That's a unit of pressure. As well as the lower esophageal sphincter, already starting out with a basal tone, a pressure of about 30 millimeters of mercury. So, when food enters into this upper area right here, you can kind of see where my arrow is. When food enters into this area, it actually causes an increase in pressure, and then as it slides through, you can see it decreases pressure back to its original value. Now, once this food is actually in this part, this is kind of signifying that this pressure change is up in this upper part. You can see that the upper esophageal sphincter relaxes, and then the bolus of food moves through, so you get an increase, and then as it slides into the midsection of the esophagus, the pressure falls back down to its normal 30 millimeters of mercury. So there is a relaxation of the upper esophageal sphincter, and then the bolus of food moves through, causing an increase in pressure, and then back to its original value. These are just telling you that as the food moves through, it actually causes a pressure change, and then it goes back to 0. So its bolus of food is here, you can see the pressure change. Then it slides down here, another pressure change, and then here you can see that final pressure change. But what's really interesting is that the lower esophageal sphincter relaxes way before that bolus of food enters into the area. So you can see the bolus of food is way up here when the lower esophageal sphincter relaxes. It's called an anticipatory relaxation. And then there's a few seconds before that bolus of food slides through, and you can see an increase in pressure and then back down to its original value of about 30 millimeters of mercury. And this again is a nice diagram showing you that the upper part is under skeletal muscle control, the lower part under smooth muscle control. So, some diseases associated with the LES, or lower esophageal sphincter. There's 2 of them that I want you guys to know: achalasia and esophagitis. So they're the opposite. Esophagitis is basically when there is a failure to maintain tone. So the LES fails to maintain tone, which results in acid bubbling up from the stomach and starting to erode the esophagus. So you guys know this as heartburn, right? It's technically known as GERD, gastroesophageal reflux disease, GERD. Gastroesophageal reflux disease. So it fails to maintain tone. It's always relaxed, and that's when acid bubbles up. Now, after a while, it can cause scar tissue, which can progress to achalasia. Achalasia is when the LES, the lower esophageal sphincter, fails to relax. And that's a big problem. That results in accumulation of food material in the esophagus, which can cause stretch and pain. And actually, it's usually a result of long-term esophagitis. So whenever you have esophagitis, itis means inflammation, right? So esophagitis usually happens first, and then it leads to achalasia. Okay, you guys good with that? Any questions so far? Esophagitis is when it fails to maintain tone. It's always relaxed. You get bubbling of acid. Achalasia is when it fails to relax. It's the opposite. Yeah?
What disease would lead to the cancer?
So usually it's when the epithelial cells are constantly being eroded and degraded, and there's a turnover. So when there's a turnover of epithelial cells on a regular basis, which doesn't normally happen, a lot of times that can cause cell cycle dysregulation and cancer. So it's just those esophageal epithelial cells are constantly being degraded, and there's a high turnover rate. All right, so moving into the stomach. The stomach and the small intestines, this is where the majority of questions are going to be asked. It's a lot of hormonal regulation. So I would say this is one that would be fair game for labeling exercise. And this would be the other. You guys have seen this one right here. So very basic anatomy. But these are the two that have been on exams in the past. Okay, so with the stomach, the upper part is called the fundus. And food actually enters into the stomach after it moves past the lower esophageal sphincter. There's something called receptive relaxation. So that's on the next slide here. Receptive relaxation is when food starts to enter into the stomach, and you have these mechanoreceptors. There's also mechanoreceptors in the esophagus too, that send a signal to the central nervous system, and then that stimulates these vagal efferents to relax the fundus. A lot of times it's through vasoactive intestinal peptide, but it relaxes the fundus in anticipation of more and more food being delivered. So it's called receptive, you can see it here, receptive relaxation. And this is one that there's always been a question on the exam relating to receptive relaxation. Describes a condition where relaxation of the fundic region, the fundus, precedes the arrival of a bolus of food into the stomach. A lot of times it occurs initially right here when the food is in the esophagus. It's all mediated through the vagus nerve, an extrinsic reflex pathway called the vagus nerve. And you don't need to know the details. Just know that it relaxes the fundus. Okay, so going back, we've got the fundus. It's the upper part of the stomach. The body of the stomach. This is where the parietal cells and the chief cells are. So, if you guys remember, the parietal cells secrete acid, and intrinsic factor. And the chief cells secrete pepsinogen. Sorry, you guys. Okay, so the body secretes mucins, pepsinogen, and acid. The antrum here is the lower half of the stomach. Also secretes mucus, pepsinogen, and gastrin. So the G cells are located in the antrum. G for gastrin. And then the pyloric junction and the duodenum. All right, so just remember that the stomach is a really violent place. After you eat a meal, there's a lot of mechanical digestion. You have 3 types of muscles. Circular muscle that constricts the body of the stomach. Longitudinal muscle that shorten the stomach. And oblique muscles that literally twist the stomach. Okay, so it's a pretty violent place with all that acid, all that mechanical digestion. There's also something called retropulsion, right? Some of the food that gets kicked down towards the pyloric junction constricts and it actually kicks it back into the body of the stomach. It's called retropulsion, and it is helping mix and mechanically and chemically digest that food. Okay, so after eating a meal, talking about the stomach, I did stop for a moment and talk about vomiting. Fancy term for vomiting is called Emesis. So if you see any drugs called antiemetics, those are anti-nausea medication. Helps you stop vomiting. So with vomiting, you guys, remember it's all about pressure changes. What usually happens is you start to retch, you breathe in against a closed epiglottis, a closed glottis, right? It actually, if you try to breathe in against a closed glottis, you can almost feel the lowering of the pressure in the upper esophagus, right? I know that sounds weird, but you can feel the lowering of the pressure in that area. And then it makes your abdominal muscles contract, increasing the pressure in your stomach. And as soon as the lower esophageal sphincter opens up, it gets propelled. Food's going to be propelled from high pressure to low pressure, and it literally is propelled out of your mouth. Okay, so that's actually different than regurgitation. Birds regurgitate their food, and regurgitation is not about pressure changes. It's actually about reverse peristalsis. Okay, cool. All right, so little detour there. Let's go back to the stomach and talk about some of the specific cell types. So the surface of the stomach, the epithelial cells, they're called columnar. They're actually very tall, rectangle-like epithelial cells that are actually contact inhibited. They're next to each other and they form very tight junctions, which prevents any kind of leakage of acid into your body. It also secretes what's called mucus. These are mucus neck cells that secrete mucins. And they secrete it on the apical side of the epithelial cells. And it's interesting that these mucus neck cells and the mucus that they secrete are just interlaced with bicarbonate. So if any acid from the stomach actually starts to degrade, it's met with a lot of mucus, thick mucus that's rich in bicarbonate. It's what's protecting the lining of your stomach. I was actually talking to a student, she's not here, who was telling me about She had an H. pylori infection when she was a kid, which is like 70 to 80% of all gastric ulcers, those are ulcers that are in the stomach, are due to H. pylori. And she said when she was a kid, she had so many ulcers in her stomach. It was just unbelievable. She could only eat crackers. So, oh, I know. Sounds horrible. Sounds horrible. So, anyway, so that's what's protecting the lining of your stomach is the bicarbonate-rich mucins. Okay, so here's 3 different cell types that you guys need to know. Parietal cells secrete acid. Don't forget that the parietal cells also secrete intrinsic factor. Okay, so just remember intrinsic factor is essential for life and it helps with the absorption of B12. B12 is actually really important in red blood cell formation. So without intrinsic factor, the result is what's called pernicious anemia. You don't get the same level of red blood cell production, and it causes anemia. Chief cells secrete pepsinogen. That's the precursor to pepsin, and it's the acid that actually converts pepsinogen to pepsin. So I can guarantee you guys there will be a question on what is chief cells, what are parietal cells? What do they secrete? And then the enteroendocrine cells are like the G cells. G cells secrete hormones like gastrin into the blood. So just another look at how those gastric pits are organized. So here's the stomach lumen, and the pits are epithelial cells. See how they're columnar? They're actually very tall. They go deep into these pits here, and then you have these different cell types. You have the mucous neck cells that produce mucins, chief cells that produce pepsinogen, and then the parietal cells here in orange that produce acid. Okay, so again, just kind of giving you an idea of how it's all organized. This is, again, starting to be redundant now. Remember, parietal cells produce acid and intrinsic factor. Chief cells produce pepsinogen, and it's the acid that converts pepsinogen to pepsin. Pepsin is an enzyme that breaks down proteins into smaller peptides. Pretty good, you guys? Okay, hopefully this is all review, and now it's starting to really kind of come together. Okay, so now we're like zooming in on just the parietal cells. Zooming in on just the parietal cells. And you guys have seen this reaction 1,000 times already. Carbon dioxide in water is converted to carbonic acid by the enzyme carbonic anhydrase. So these parietal cells actually have carbonic anhydrase inside. Carbonic acid is then converted to bicarbonate and protons. And just like in the kidney, for every carbon dioxide molecule, 1 proton is secreted into the lumen of the stomach, and 1 bicarbonate is actually absorbed into the blood. And bicarbonate is transported across the basolateral membrane by the chloride bicarbonate exchanger. Okay, so after you eat a meal, you literally secrete hydrochloric acid. See how chloride follows the proton movement? So you are secreting hydrochloric acid until the interior of the lumen of the stomach actually can fall to a pH of 1 to 2. That's how acidic the stomach can be. And it's this proton potassium pump. It's a primary active transporter because it requires ATP, literally pumps protons into the stomach lumen, and this potassium channel just makes sure that the pump keeps working. All right, So after you eat a meal, not only do you secrete hydrochloric acid, but you also absorb more bicarbonate. This is called the alkaline tide, right? The alkaline tide. You have just delivered an enormous amount of new bicarbonate into the blood. So if you throw up all of that acid that's just been delivered to your stomach, and you've just delivered all of this bicarbonate in your blood, you're going to become profoundly alkalotic. It's going to be a metabolic alkalosis. Okay? Any questions? Metabolic alkalosis. All right. So acid production by the parietal cells in the stomach depends on the generation of carbonic acid. And then there's subsequent movement of hydrogen ions into the gastric lumen. That's a result of the primary active transporter, the proton potassium pump. So most of the acid relieving medication, acid relievers, they target this pump. Omeprazole, that's like, is it Nexium, the purple pill? Nexium, the purple pill. It's actually targeting this particular pump. All right, so what regulates these parietal cells? There's different hormones, molecules. This is a paracrine signaling molecule, and neurotransmitters. There's one inhibitory molecule, somatostatin. Like I said, somatostatin inhibits everything, even parietal cells. And then there's 3 stimulatory signals. And what they're doing is they're just promoting the insertion of these proton potassium primary active transporters into the membrane so that you can secrete more acid. Okay, so how are these regulated? I told you about the difference between parietal cells and these paracrine cells called ECL cells, enterochromaffin-like cells. Enterochromaffin-like cells. So here's where I introduce the cephalic phase. This is what happens when you just start to smell food or think about food. And the gastric phase, where you're really ramping up acid secretion, and then there's chemical digestion of food that's actually entered into your stomach. So this upper part here is a parietal cell. This is the acid secreting cell that lines the stomach. And then right next to it are these ECL cells. So during the cephalic phase, when you're just smelling food or thinking about food, you guys starting to get hungry? No, not yet? Okay. What happens is you start to already produce a little bit of gastrin, a little bit of acetylcholine through those vagus nerves. But histamine is not on board yet. It's just a little bit of gastrin from those G cells. It's feeding back. See, this is the circulatory system. It was secreted into the circulatory system, and then it fed back to the parietal cells in the stomach. Gastrin has receptors on those parietal cells. Along with the vagal nerve is actually increasing, it's being stimulated and releasing acetylcholine, the neurotransmitter that's also triggering these parietal cells. So you're getting a little bit of acid secretion. Some of the gastrin, some of the acetylcholine, you're getting a certain amount of acid secretion. You guys remember this, we talked about this in class. These are GQ coupled receptors because they increase intracellular calcium. But as you start to eat food, and now food is now entering into your stomach, more and more acetylcholine and gastrin is going to be released. It actually starts to ramp up the system. And now that's where the ECL cells come into play. As soon as the ECL cells are stimulated and they start to release histamine, this is a GS coupled receptor, that's when this is the trifecta. we talked about the word potentiation. This is where you're going to get the maximum amount of hydrochloric acid secretion because now all three of these molecules are stimulating the parietal cells. Okay, so potentiation means that the amount of hydrochloric acid is greater than the sum of each of the individual parts. So for instance, acetylcholine, once the cells, acetylcholine stimulates the cells, it produces a little bit of acid secretion. Gastrin alone produces a little bit of acid secretion, and histamine alone produces a little bit of acid secretion. But when all three are on board, the amount of acid secretion is greater than the sum of the individual molecules. Called potentiation. And that's what happens during the gastric phase. Okay, so parietal cells are obviously super important. Very important. Okay, so then we actually went through, this is just more of the same. We talked about what is the difference between the cephalic phase and the gastric phase. So you can see here the cephalic phase is before you start eating food, and it's only mediated by these vagal efferents from the central nervous system. You can see the vagal neuron, the vagal nerve actually releases acetylcholine, and it's actually directly stimulating those parietal cells. It's also mediating gastrin-releasing peptide that is stimulating the G cells to produce gastrin, and that's feeding back to the parietal cells. But then once you start to eat food, there's these stretch receptors, mechanoreceptors, that are sending a signal to the central nervous system and back. And you can see that there's long reflexes, that would be to the central nervous system and back, and these short reflexes that just go to one pathway to the next within the stomach to release more acetylcholine, more gastrin, and that's when the ECL cells come on board. They're releasing histamine, and then this will be the maximum hydrochloric acid secretion. So I've included some tables just to help you. You can see the cephalic phase and the gastric phase. The end result is an increase, both of them, in hydrochloric acid secretion. More tables. Again, there's long and short reflexes. The long reflexes go all the way to the central nervous system and back. The short reflexes are confined to the stomach. Mixing, acid, lots of things going on here until just a little bit of food is delivered into the small intestines, the duodenum. And then everything shuts down. This is called a decrease in gastric emptying. So what happens is you get an increase in the pyloric contractions. Now it's not about just dumping all that food from the stomach into the intestines. It's about piecemealing it little by little from the stomach into the small intestines. So remember the intestinal phase. This always confuses students. The intestinal phase is about decreasing gastric emptying. Decreasing gastric emptying. It's not about emptying, dumping all of that food into the small intestines. Again, it's about slowly piecemealing that food into the small intestines as slow as possible to maximize digestion and absorption. How are we doing? Okay, so there's different sensors. Once you start to get, this is called the intestinal phase. Once you get a little bit of food into the small intestines, you have these sensors that are going to sense lipids, acid, and just solute, right? Anybody remember the cells that detect lipids? eye cells. Eye cells. Eye cells detect the lipids. And as soon as they detect lipids, they start to secrete CCK, cholecystokinin. And you won't have to memorize that. The test will say cholecystokinin, and then in parentheses it'll say CCK. So CCK decreases peristalsis, the motility, increases pyloric contraction, which decreases gastric emptying, and it triggers the pancreas to release lipases. Makes sense. It's detecting fats or lipids, and it's triggering the pancreas to release lipases into the small intestines to break down that fat. It also causes the gallbladder to contract to release bile. And then, of course, it causes the sphincter of Oddi to relax, to deliver all of those lipases from the pancreatic duct and deliver the bile. Bile helps emulsify the fat. The lipases help to break down the fat. Okay, so remember, you do need to know the anatomy here. And I'm going to switch to this one. This will help you too. The CCK secreting cells are the eye cells. They trigger the pancreas to release lipase and trigger the gallbladder to contract and release bile. Also cause the sphincter of Oddi to relax. It also decreases peristalsis, and it decreases gastrin production, decreasing gastric emptying as well. Okay, so let's go to this next one. Secretin secreting cells are the S cells. Secretin secreting cells are called S cells. They're detecting acid that is being delivered from the stomach into the small intestines, and just simply these S cells trigger the pancreas to release bicarbonate, right? That neutralizes the acid in that area. Where does that bicarbonate come from? The stomach, the alkaline tide. So the bicarbonate that is released from the pancreas is actually coming from the circulatory system, from that alkaline tide. And then, let's see here, GIP secreting cells. I would remember GIP as glucose dependent insulinotropic peptide. So it's detecting glucose dependent, and it's triggering the pancreas to secrete insulin. And then there's also osmoreceptors that are just detecting a lot of solute, and they're just feeding back to decrease acid secretion and gastric emptying. Okay, so this is a lot, you guys. Acid secreting cells are called what? Parietal cells. G cells release gastrin. I cells, CCK. S cells, secretin. Yes. So here's just a summary slide. They'll be very easy. The questions will be just kind of like this. I mean, a lot of those will be. So you should be able to answer those ones really easily. Okay. All right, so let's skip through. These are just some flow charts. One's about secretin, one's about CCK. We did talk about the anatomy of the small intestines. What I want to do is actually kind of skip to where I know there's going to be some questions. Motility is a big one. Okay, so I'm just going to make it simple for you guys. The motility in the small intestines is, there's three of them. Segmentation, peristalsis, and the migrating myoelectric complex, which sweeps through the small intestines a couple hours after you eat a meal, just to get rid of that last bit of food that's there. So those are the three types. Segmentation. This is all about mixing. Peristalsis is about moving food down the line. Sweatpants analogy. And then migrating myoelectric complex is just about sweeping through the small intestines, getting rid of that last bit of food, delivering it into the colon a couple hours after you eat a meal. It takes about 90 minutes. Okay, so then we talked about some of the enzymes that break down protein, carbohydrates, and fats. So the major ones that break down proteins are trypsinogen, chymotrypsin, and carboxypeptidases. So try to know those: trypsin, chymotrypsin, and carboxypeptidase. Peptidase actually should trigger you that these break down proteins. Okay. Lipases break down fats. Amylases break down polysaccharides. And then there's ribonucleases and deoxyribonucleases that break down nucleic acids. And that's, I mean, there's a lot of redundant slides. This one, lipases, proteases, amylases, nucleases, right? So it looks like a lot of information, but they're very similar. They're just more redundant. So I heard an interesting comment because I have had gallbladder issues. Now you guys know that I have like a goiter and I have gallbladder issues. Okay, so somebody told me the other day I better get it checked out because gallstones can get lodged in those common ducts, right? And if that's the case, you can get trypsin to actually stay in the pancreatic duct, which then starts to degrade the epithelial cells of the duct and actually start to affect pancreatic function. So can be very serious. So after I get back from all my travel this summer, I promise I'll go in and check it out. But I can't right now, which is terrible. Okay, so all right, so I wouldn't worry about enterosymbionts or exosymbionts or endosymbionts. Don't worry about that. Okay, we did talk a little bit about how carbohydrates are actually broken down. Remember salivary amylase and pancreatic amylase. You don't need to memorize the different polysaccharides, disaccharides, and monosaccharides, but I do want you to know something about the transport. So SGLT is the sodium glucose transporter. And you can see it's a secondary active transporter that transports glucose against its concentration gradient, which then allows it to move across the basolateral membrane by facilitated diffusion. Why is this important? When we're talking about oral rehydration therapy, it's thought that the sodium glucose transporter is actually transporting water with it. There's not a whole lot of known aquaporin channels in the gut, which was always very enigmatic. Now it's known that water is being transported with the sodium glucose transporter. So it makes sense that you can't just give, if someone's severely dehydrated, you can't just give them pure water. They have to have some glucose in it or electrolytes like sodium in it. Then you can absorb water much easier. Okay, so then going back to our sweet taste receptors in the gut, this is kind of giving you an idea of with low glucose levels, you don't have as many GLUT2 expressed in the apical membrane. GLUT2 are these orange ones. However, in the presence of high glucose levels, now you've eaten something very sugary or artificial sugar. Now you can see that these GLUT2 carriers are inserted into the apical membrane, so you can actually absorb more glucose after you trigger those sweet taste receptors. So, kind of interesting. All right, so this is telling you again, there are amylase in the mouth and amylase, oops, that's that one. Going back to proteins. Proteins start to break down in the stomach through pepsin and then in the large intestines by trypsin, chymotrypsin, and carboxypeptidases. In this case, there's another secondary active transporter that's transporting amino acids against its concentration gradient using the energy of the sodium gradient, another secondary active transporter. So very similar to the previous ones. Sorry guys, I'm going to turn this off. My phone is blowing up. Oh, that's okay. It's Julia's fault. It's all the physiology TAs. Okay. No worries. All right, so let's see here. Bile. Okay, so bile is a combination of bile salts, lecithin, bicarbonate ions, cholesterol, bile pigments, and trace metals. And it's recycled in the stomach and the liver. Bile is an amphipathic molecule. It has a polar end and a nonpolar end that essentially surrounds these smaller fat droplets. Now there's the polar end is actually facing outward, so they will repel and you won't be able to get reaggregation. Yes? Isn't that used?
I don't know.
Oh, I would guess that you could actually. Yeah, interesting. I would think that you could. Yeah, it's interesting. I've done experiments before where you have these big fat droplets in water or vinegar, and when you add bile and shake them up and just let them sit again, you can see that the one without bile will reaggregate, the other one won't. So it really shows nicely the emulsification of fat with bile, which is pretty cool. Okay, so once the bile helps to emulsify the fat, the lipase can get in there and break it down into monoglycerides and fatty acids, which can easily move across the epithelial cells. What's interesting is that these are repackaged, the fatty acids and monoglycerides. They're repackaged into chylomicrons, which are triglycerides with a protein attached to them, and then delivered into the lymph system, also called the lacteal system. Where do they go? Chylomicrons are then distributed to adipose tissue where they're stored. So this is giving you an idea. Triglycerides and protein form the chylomicrons. And then bile is recycled. 95% of the bile is recycled, only 5% is lost in the feces. Okay, CCK, we talked about diarrhea. Diarrhea, secretory diarrhea is when the transport properties change, secreting chloride, and then water follows the chloride movement. This is what happens with cholera. Actually, the CFTR channel, because chloride is the transport, that's the molecule that's transported into the small intestines. That's what's responsible for the secretory diarrhea, and then water follows. That's why people that have cystic fibrosis, when they don't have that chloride channel, are somewhat immune to cholera. They don't get as sick. Osmotic diarrhea, examples are lactose intolerance, right? Because lactose doesn't get broken down. The person is usually devoid of the enzyme lactase, which acts as an osmolyte drawing water into the small intestines, causing diarrhea. Irritable bowel syndrome, IBS, or other inflammatory diseases like Crohn's disease cause malabsorptive diarrhea, which is really another type of osmotic diarrhea. You don't get absorption, and all of those undigested food or nutrients stay in the small intestines, drawing water in, causing an osmotic diarrhea. Motility related is the same thing. If the food is moving through your small intestines too fast or too slow, it can cause a motility related diarrhea, just another type of osmotic diarrhea. And then dysentery is when you have blood in your, and that can be caused by an ulcer or other related inflammatory diseases. All right, colon. We'll go through this really quickly. Ascending, transverse, descending, sigmoid, rectum, and anus. So do know this structure, this simple diagram as well. You do have a lot of microbes that are in the colon. These microbes are responsible for the production of vitamin K. So because there's no microbes in newborns' colon, they don't have the ability to produce vitamin K when they're first born. And vitamin K, the absorption of vitamin K is really important in the ability to clot, right? Blood clotting is important. Vitamin K is really helpful in blood clotting. So this can cause hemorrhagic disease of newborn. That's why they whisk those babies away and maybe give them a shot of vitamin K in their heel, because the microbes aren't producing vitamin K at that time. So we talked about motility in the small intestines, remember? Segmentation, peristalsis, and migrating myoelectric complex. In the large intestines, we only have two, hostration and mass movement. So these pouches, you can see here, these big pouches in the large intestines are called hostra. And hostration, each one of the pouches individually contracts, right? Mixing and forming feces like big mud pies. That's gross, but true. All right, that's called hostration. Mass movement, you guys, when you start to feel that urge to go, is when the ascending colon contracts. And at the same time, the transverse colon relaxes. And that actually helps to push fecal matter down the line. 2 more slides, you guys, then we'll move on to the endocrinology. This is the defecation reflex. This is a true reflex because the initial response only goes to the spinal cord and back. That's why people that have spinal cord injuries have no control over defecation. Okay, so simply, if you remember anything, the defecation response starts in the rectum. It's initiated in the rectum. Okay, so this is where it starts. Stretch, distension is detected in the rectum. It sends a signal to the spinal cord, which causes the colon to contract and the internal anal sphincter to relax. It automatically relaxes when this defecation reflex is initiated. But nothing should happen until you voluntarily relax the external anal sphincter under skeletal muscle control. You're in control of the external anal sphincter. Internal anal sphincter under smooth muscle control, and it's just part of that reflex, completely involuntary. So if you're near a bathroom, you relax the external sphincter and you go number 2. If you're not near a bathroom, you may contract the external anal sphincter, and then everything in the rectum through reverse peristalsis is actually moved back into the colon. Awesome. Okay, any questions, you guys, about the defecation reflex? The main thing is it's initiated through stretch of the rectum, stretch or distension of the rectum. Okay, this is complicated. I'm going to make it super simple. Ghrelin increases appetite. It's the only one. Leptin and peptide YY decrease appetite. Leptin was thought to be that magic diet pill because it decreases appetite. Little did people know that at the time that it actually increased the amount of fat that adipose tissue stored. So it wasn't the wonderful appetite suppressant that they thought it was going to be. All right, you guys, we'll go through it. I think it won't take very long. I know you guys have another review session. Got the marathon review session day. All right, so I'm just going to go with this hormone worksheet, and we're just going to fill it out together. What's that? Not yet, but it will be. I haven't filled it out yet. I'm going to actually fill it out with you guys right now. Okay, so, yes. Oh, yes.
For the very last slide, it says, what is reflux esophagitis? What is that?
Reflux esophagitis. So that's heartburn. Yeah. Where did you guys see that? It's on the last slide?
The very last.
Oh, okay. Yeah, that, let me see. Is that, is it a sample question? Is what it is. Okay, can you read it to me?
Yeah, what is reflux esophagitis? A, inflammation of the esophagus due
Yep.
to histamine release. B, a condition in which the lower esophageal sphincter fails to relax. C, a condition in which the lower esophageal sphincter fails to maintain tone. And D, a condition in which the esophageal wall weakens, leading to megaesophageal.
Okay, so it's definitely, so what is, the question is, what is reflux esophagitis? So it sounds like it is where the lower esophageal sphincter, did you say fails to maintain tone? Yes. So that's the right answer. It's also an inflammation, though, of the esophagus.
Yeah.
Yeah. But the cause is, let me see. Yeah. Oh, it's not due to histamine release. Yep. So it's number C. It's the lower esophageal sphincter fails to maintain tone. All right, so let's go ahead and go through this. Let me see if I can zoom in on it a little bit closer. Okay. Yes, yeah, definitely. Sure. Read it to me.
Why is blood bright red?
Yeah. Yeah. So that was part of the alcoholism. The reason why it is bright red is because it hasn't been digested by the stomach. So if blood enters into the stomach and acid gets a hold of it, it actually causes the blood to look like coffee grounds. So in this case, that Mallory-Weiss tear is because of those pressure differences when he vomited, and it tore the lower esophageal sphincter and never entered into the stomach. So it's bright red because it never got digested by stomach enzymes and acid. Okay, so let's go ahead and start at the top here. You don't have to write this because like I said, but I'm going to just be more complete here. CRH is corticotropin releasing hormone, or CRH. It is released. Now remember, anything under this column is being released from the hypothalamus. It travels by those portal vessels to the anterior pituitary, where it triggers those endocrine cells to now release ACTH, which is adreno. Oops, did I spell that right? Adrenocorticotropic hormone, or ACTH. Anybody remember where this goes? Yes, adrenal gland. Adrenal gland, specifically, is it the cortex or the medulla? Yes, did you say it? Cortex, yeah. Cortex region. Okay, so what is its action? It stimulates the secretion. Oops. Of what? Glucocorticoids. Like what? Glucocorticoids. Cortisol. Thank you. Cortisol. Cortisol. Cortisterone. Sorry, it's been a long day. And cortisone. Yeah, cortisone. Okay. Okay, so I'm going to put something else here too. What are some of the actions? Let's just increase this a little bit. What does it do? Do you guys remember when people get super stressed out? What does it do? Protein synthesis or catabolism? Catabolism. Fat catabolism. Remember, people get super thin because they start breaking down muscle and fat. What does it do to blood glucose levels? Increases blood glucose levels. So it opposite acts. I'll just say increase blood glucose. It does the opposite of insulin. Increase blood glucose levels. Glycogenolysis. Oh no, I'm going to say gluconeogenesis. Okay, yes.
Can we just memorize like the CRH if you want us to know like the full name?
Just memorize CRH. Yeah. On the exam, it'll say corticotropic releasing hormone, parentheses, CRH. Okay. All right, so what are some of the diseases we talked about? What is a hypersecretion of glucocorticoids cause? Cabby, the horse. Cushing's disease. Hypersecretion of cortisol. Make sense? Actually, this also, Addison's disease, I talked about that as hypoaldosteronism. You could also say it's actually Addison's disease is really adrenal insufficiency. So you could also say that hyposecretion of cortisol also causes Addison's disease. There's some crossover. All right, I think that's it, right? Not too bad. Okay, so TSH. No, we're going to go TR. Okay, so this is thyrotropin releasing hormone. What triggers thyrotropin releasing hormone? Yeah, but what specifically is causing the release of thyrotropin releasing hormone? Perfect. It's low levels of T3 and T4. Okay? And that sends a signal to the anterior pituitary to release thyroid stimulating hormone. Okay, one thing, I'm going to stop right here. One thing that I want you to know oh, I got these mixed up. I put the parentheses around the wrong thing, but okay, you guys know what I mean. One thing that I want you to know is do memorize what's coming from the anterior pituitary and what's coming from the posterior pituitary. Okay, so the other thing is people that have goiter, what would you, like a goiter, like I talked about before, because of a lack of iodine, what would you predict would be their levels of TSH? Would it be high or low? Very high, right? Very high. Thyrotropin releasing hormone would be also high. T3 and T4 levels would be very low. Yeah. Okay, so what's the target cell? Thyroid gland. What's the action? Stimulates the secretion of T3 and T4. What are the diseases associated with that? Hyperthyroidism and hypothyroidism. Okay, do you guys remember some of the symptoms though? You might need to know the symptoms. Hyperthyroidism, loss of weight, nervousness, anxiety, high energy, heat production. Hypothyroidism would be the opposite. That would be fatigue, weight gain, cold intolerance, always feeling cold. You guys pretty good with that? Okay. All right, so this one is an interesting one too. Gonadotropin releasing hormone. Okay. Gonadotropin releasing hormone. Okay. FSH, follicle stimulating hormone. Gonadotropin releasing hormone. LH is luteinizing hormone. Okay. I'll fill this out later. We don't have to go through all of it. But. All right, so what's the target cell? What's that? Yep, female ovaries, male testes. And I'm going to say Sertoli cells. So what does it do? Females, what does it do? Involved in maturation of the follicles. Involved in follicular development. Oops, there we go. Males, what do the Sertoli cells do? You guys remember spermatogenesis? Spermatogenesis. Sertoli cells make sperm. And we really didn't talk about any diseases, so we're going to leave it at that. Good question. No. Yes? Not sure. Okay, yes. I'm trying to decide, is it progesterone or is it estrogen? And off the top of my head, I don't know. So we're going to go with what your notes say. Estrogen production. All right. Obviously, you won't need... Okay, perfect. Obviously, you won't need that for the exam. Okay, LH, luteinizing hormone. I'll just do that while you guys are... Follicle stimulating hormone. And then LH is luteinizing hormone. Okay, so target cells, same. Female, ovaries, male. Okay, but instead of the Sertoli cells, I talked about this, these are the Leydig cells. Leydig. So what does it do? In females, you guys remember? A surge of luteinizing hormone. Yes, I'm going to use that word instead of responsible. Induces ovulation. Males, what does it do? So the Leydig cells produce testosterone. I'll open this up. All right, so this isn't very original. Prolactin. PRH is prolactin releasing hormone. It causes prolactin to be released. Anybody know the target cell? Thank you. Target cell. Mammary gland. Mammary gland. And what does it do? No, close though. Milk production. Ha, milk production. And we didn't really talk about a disease, so I'm leaving that blank. And then growth hormone releasing hormone. Growth hormone. Eek. What are the target cells? I would say various. There's, I mean, the heart, the liver. I'm going to say various. What is the action? This is important. Acts through IGF-1 to stimulate growth. Also synergistic with thyroid hormones. The other thing is it also does the opposite of insulin. It acts to increase blood glucose levels. Okay. So what are some of the diseases? What if there's too little? Let me just make sure I want to include all that. oops, stimulates gluconeogenesis, blocks glucose uptake, so it elevates, does the opposite of insulin, elevates blood glucose levels. So it also helps to stimulate RNA and protein synthesis. Okay, so what are some of the diseases? What happens when there's too little growth hormone? Yep. Hyposecretion equals pituitary dwarfism. This is different than achondroplasia, which is a different type of dwarfism, a recessive. That's where there's some problems with connective tissue. So in that case, achondroplasia is where with dwarfism, they're not proportional. So their head is larger than their body is. They have some malformations, if you will, okay? With pituitary dwarfism, they have a juvenile appearance, but they're completely proportional. They're only about 3 feet tall, though, okay? And that doesn't really happen anymore. So pituitary dwarfism is what happens with hyposecretion. Hypersecretion that would be gigantism. Acromegaly. Anybody remember the difference between gigantism and acromegaly? Puberty, yes. If the pituitary tumor actually occurs in puberty, that would cause gigantism. After puberty, it would cause acromegaly. Did you guys notice how close the pituitary gland is to the nasal cavities? Now what they do is it's a lot less invasive. They'll go through the nasal cavity to take out a pituitary tumor. It's actually pretty slick. I know, right? I know. Right. Okay, so you guys pretty good with that? All right. ADH. Okay, what is vasopressin? What's the target cell? Kidney. Right, you guys? Kidney. I would even go as far to say the collecting duct. Well, no, I'd say distal tubule and collecting duct. What's its action? Stimulates the reabsorption of water due to the insertion of aquaporin channels, water channels. Disease. What are the 2 diseases that I really wanted you guys to know today? Perfect. Neurogenic, and nephrogenic. Diabetes. Insipidus. Perfect. Why is it called diabetes? Because you can't concentrate urine. So you lose a lot of water, and all the electrolytes in your blood are high. Not just glucose, but you have low body fluid and high osmolarity in the blood. Neurogenic means that the problem is in the brain, the hypothalamus. Neuro meaning brain, genic meaning origin. So head injury would do it. I would even say long-term chronic alcoholism, because remember, alcohol inhibits vasopressin release. Nephrogenic diabetes is a problem with the receptors for vasopressin. So it's at the kidney. Nephro means kidney. Okay, good job. Oxytocin, what's the target cell? I would also say various, because it does a couple of different things. It's responsible for milk ejection and labor. And then I'm just going to put positive feedback mechanism. Right? When you're in labor, when women are, well, not guys, but when women are in labor, what happens is when you get stretch of the cervix and contractions, it feeds back to the posterior pituitary. Remember, these two are coming from the posterior pituitary. And that causes more oxytocin release, which then causes further dilation and further contractions, which feeds back to release even more oxytocin, and the whole cycle keeps going and going until some major event like labor occurs. Positive feedback mechanism. Classic positive feedback mechanism. Okay, so if I were to ask you, if you actually cut any kind of communication between the hypothalamus and the anterior and posterior pituitary, but you only cut neurons, which one is going to be affected? Yeah, the posterior. So vasopressin and oxytocin would be the only ones not released if you transect or cut neurons from the hypothalamus to either the anterior pituitary. So remember, it's these hormones. Oops, these hormones from the hypothalamus are what's responsible for secreting these particular hormones from the anterior pituitary. All right, let's keep going, you guys. We're getting there. We didn't really talk about any diseases associated with oxytocin, so I'm not going to write those down. T3, T4, what are the target cells? Various, many. I would say many. What do they do? Yes. You were close. So that's calcitonin. Yes, so I can write that there. Calcitonin is responsible for inhibiting, actually, I would say decreasing bone resorption. So it inhibits those osteoclasts. So if there's very high calcium in the blood, the last thing you want to do is to degrade bone. So what it does is it inhibits those osteoclasts. So it really is responsible for decreasing bone resorption. Okay, but what does T3 and T4 do? Whoa, what? Oh, I put an equal sign there. That's why. What does T3 and T4 do? Yeah. Perfect. So what it does is it sensitizes the cell to epinephrine, right? It makes it much more sensitive to epinephrine, which increases metabolism by increasing cellular respiration and oxygen consumption. Okay. Cool. So T3 and T4 both do that. All right, so we already talked about hyper and hypothyroidism too. Okay. Okay, so again, moving right along, calcitonin. I would say bone. In fact, if we want to be more specific, we can say osteoclasts. Oh, here's a good one. Osteoclasts. Oh, I spelled that wrong. So what is the disease associated with this? Osteoporosis. Yep. Most of the drugs that target are responsible for the osteoclast. They inhibit osteoclasts as well. That's like Boniva. What are some of the ones that you see on TV now? Fosamax. What's that? Yes, yes, it really does. It causes severe TMJ. What's that? That's, and yeah, really some bad problems with the jaw. Yes.
So is osteoporosis from too much or too little? Or just like the way?
Yeah, so osteoporosis is due to thinning, where you're getting degradation of the bone. And a lot of times it just happens with age. So most of the drugs, there's another type of cell called osteoblasts, and that builds up bone. Osteoclasts actually degrade the bone, like that picture that I showed. It is a problem with the regulation, and just in general, you lose bone as you get older. So, like I said, most of the drugs that people take are specifically targeting the osteoclasts so that you don't get further breakdown, but they don't really target the osteoblasts to promote bone growth. So, I know that doesn't help, but as you age, I'm not sure which one of the cells actually goes awry, or if it's a hormonal thing. But I actually don't think it's due to dysregulation of hormones. I actually think it's due to just the thinning of the bones. Yeah, the degradation of the bones. Yeah, that's not a great answer, but at least you know a little something about osteoclasts and osteoblasts. So I do know that it's actually just about your size. Even smaller men can be more susceptible to osteoporosis. So people that just have thinner bones in particular are more susceptible. Okay, so my mom actually has osteoporosis, and the drugs that I was just talking about, Fosamax, sounds pretty horrible in some ways because she only takes the drug like maybe once every 6 months, which is great. But she has to sit upright for like an hour because it can really have effects on degrading the esophagus. So you can't lay down for like a half an hour to an hour after you take it. It just doesn't sound like, oh, it sounds horrible actually. All right, so let's keep going, you guys. Adrenal gland, cortisol. Again, various tissues. This is part of the stress response. And what it does is, actually we already did this with ACTH. It increases blood glucose levels and promotes protein and fat catabolism, breakdown. Okay, I also want you to remember the locus ceruleus too. You guys remember that. Locus ceruleus, S-O-E-R-U-L-U-S. and that's responsible for attention. For attention and arousal during stress. Okay, oops, levels. Okay, oh, I know what happened. Okay, so let's see. What are some of the diseases? Cushing's disease. Aldosterone. I'm going to say kidney, even though there's some various. Promotes. So this is aldosterone. Promotes salt and water reabsorption. What were some of the diseases? Too much aldosterone. Hyperaldosteronism. What would this cause? If you got too much salt and too much water reabsorption, what would that cause? High blood pressure. High blood pressure. It's called Conn's disease. Okay, hypoaldosteronism. Low blood pressure, fatigue. Remember the little puppy? Depressed. I think he was a little bulldog. Addison's disease. All right. Epinephrine. Various. What does it do? It causes anxiety, nervousness, tremors, also increases metabolism. What else would cause anxiety, nervousness, and tremors? Hyperthyroidism and a surge of sympathetic tone, nervous system. Fight or flight. So just remember that as your fight or flight. Okay, parathyroid, going back. What is the target? I'd say bone. I'm going to put osteoclasts. So, how would parathyroid hormone be triggered? What triggers, I should say this, what triggers the secretion of parathyroid hormone? That's calcitonin. Yep. So, secreted in response to low blood calcium levels. So what would it do? Enhance or decrease osteoclast activity? Decrease osteoclast activity? Increase osteoclast activity. right? So now it's going to cause resorption of bone. What that means is it actually goes along and degrades the bone and releases the calcium into the blood. So it's going to help raise calcium levels. What else does it do? Increases osteoclast activity, promotes calcium absorption from the small intestines with the help of calcitriol. Citriol. Remember, that's made by vitamin D. Made from vitamin D. Okay, will you guys remember that there's a difference between calcitriol and calcitonin? That's hard, right? They're very similar. What is calcitonin? Where is that coming from? Calcitonin. The thyroid, the C cells from the thyroid gland. It's secreted in response to high blood calcium levels, and it inhibits osteoclasts. Calcitriol is made from vitamin D that helps with the absorption of calcium from the small intestines. Almost done, you guys. I'll clean this up when we get home. Okay, so we didn't do, so I'm just going to put, just so everybody doesn't, we already covered atrial natriuretic peptide in the kidney section, so I'm just going to put not applicable. We really don't need to go through renin-angiotensin again. You guys know what that does. Angiotensin is a powerful vasoconstrictor that promotes the synthesis and release of aldosterone, which, as you know, aldosterone promotes salt and water reabsorption. All of this to get your blood pressure back up to normal. Okay, we didn't talk about this, but in the kidneys, erythropoietin is a hormone that increases red blood cell formation. So at high altitude, you start to release erythropoietin, and you increase the amount, the levels of red blood cells. But we didn't really cover that in class, so not fair game. All right, but we did cover the pancreas. This is the last thing. What's the target cells for insulin? Various tissue. What does it do? Promotes glucose uptake. What does it do to blood sugar levels? Decreases blood glucose levels. Okay, so what are some of the diseases? Sorry. What did I do? Oh, I know. Can't put those dashes there. Okay, so what are some of the things that we talked about? Diabetes. I should have said this though, so people at home, I hope you're listening. Diabetes mellitus. Okay, that's different than diabetes insipidus. Type 1 is what? Yes, type 1 is juvenile diabetes, which is a autoimmune, I'll say that, autoimmune that attacks, autoimmune disease that attacks beta islet cells in the pancreas. All right, diabetes mellitus type 2. I would call this insulin insensitivity. Do you know what actually happens, you guys, when you are a couch potato? If you don't exercise at all, you actually don't express GLUT4 carriers, transporters. And so you can't take up as much glucose as a person that exercises on a regular basis. So you can, it can lead to diabetes type 2. You can have insulin that's circulating in your system. You're just not able to react to it, take it up. Okay, glucagon. We're almost done here. Various tissue promotes. Okay, what does it do? It does the opposite. So it inhibits the uptake of glucose and increases blood glucose levels. Okay, and we already talked about diabetes. Somatostatin. No, I'm just going to put this on here really quick though. Inhibits both insulin and glucagon. Okay, marathon session, but we are done. Did we make it on time? Yes, pretty good, pretty good. Glucagon. Yes, we are done.
Cool. I was just making sure because we reserved it for 4.
Okay, we're done. We're done. Yes.
Thank you.
Yeah. All right, you guys. We are done. I will put this on Moodle right now. Before I leave this room, I will put this on Moodle. Yeah, good job, you guys. Thank you for staying. Good luck. Hope to see some of you guys. Actually, I would encourage you guys to wait till May 10th. There's a lot of material, but I know if other people, if you can't do that because you have a lot of other tests, I get it. But let me know if you have any questions. And I will post this right now too. Well, it has to upload to YouTube, but